Okay.
Hi, everybody, and welcome to another episode of ASAP Pathway. I have the honor of talking today, having a much needed conversation with my friend and colleague, Dr. Ilya Lipkin.
Hello.
It's really early where he is, so I'm super, super appreciative that
Not that early.
he's joining me this morning. I wanted to just give you guys a little bit of a background. Dr. Lipkin was born in Moscow, Russia. He immigrated to the United States with his family in 1990. Working full-time, he simultaneously earned a bachelor's degree from New York University. He went on to earn his dental degree from NYU's College of Dentistry. Dr. Lipkin then completed his residency in orthodontics in the college's Department of Postgraduate Orthodontics. An education enthusiast, he went on to get additional training in the Roth-Williams philosophy, which believes orthodontics should address all the structure of chewing, especially the jaw joints, which lacks in traditional orthodontic education today. And without further ado, hi, Dr. Lipkin. Hi, Ilya.
Hello, Stacy. How are you?
I'm doing really good. And I that is the other thing too. I wanted to say we're just honored that you're not only a friend, but you're in ASAP Pathway with us, and just the teaching that you do, the fact that you incorporate the jaw joints, that's not very typical in orthodontics. But I wanted to talk about your journey a bit because you're unique. You're a trailblazer. You're a maverick. So I just wanted to talk. You're so welcome. I just wanted to talk about what happened. Okay, because we know what the typical orthodontic residency typically is. Why is your practice so different? What happened? What changed your thought processes and started you on a different path?
I think it's all started with just in general how things fell into my lap, so to speak. I think I used to work full time in college and dental school, and I had we just did calculations. I did 13 different jobs over the course of my education.
What were some of the jobs you had in dental school?
Delivery bread, did the IT work for college dentistry. I did database administration. I was working in a nursing home first as a bed maker, then I was a nursing assistant, then licensed practitioner, then that graduated into pulmonography, pulmonosomnography. So I did the sleep tests for a living, and that's I think probably how it got me into the airway in the first place, because the airway was always on the back of my mind because I saw sleep tests and I saw sleep deprivation. And
you did that in dental school?
I did that in dental school, yeah.
How did you do that? Because that PSG, I mean, that shift is rough.
So essentially, it's my wife's uncle is a neurologist, and he worked with another sleep physician, and that sleep physician needed a pulmonosomnography technician, and
wow.
we had a travel equipment, so I would go to patient's house, set them up, start the recording, come back in the morning, take it off. And I didn't process the data, so my uncle processed the data, but I just was very close to seeing how people affected by lack of sleep.
Interesting.
When I started orthodontic department, it's always we always talk about it. We the mouth breathing and how bad it is, but it was never really, we never ventured beyond that. It was kind of always. It was there, but it wasn't there. And then you start doing things, and then you so when I was in NYU in ortho department, I listened to a lecture by Ron Roth, which is an orthodontist whose whole philosophy of orthodontics based on the jaw joints. And airway was not really part of their philosophy, but the jaw joints were. And one of the reasons when I listened to him, he really struck the nerve, because nothing in orthodontics was predictable. Like, I've started cases in as a resident, and I was fortunate enough to start working in various practices. And one of the practices that I started working in, it's kind of funny. I was literally in my first week of orthodontic residency, and a friend of mine called me and he said, "Would you like to start moonlighting in this practice? It's a general practice, but they have an orthodontist on staff. It's a giant practice, like 17 chairs." And I said, "Listen, I've been in a week of residency. I just, barely know how to put the braces on." And he said, "Doesn't matter. As long as you just put the brace on correctly, you'll do better than our current orthodontist." And I went into that practice, and the guy would just put 4 braces in the front teeth and straight piece of wire. And then he would extract teeth, and the spaces would close by themselves, like over a period of a couple of years. And he just changes colors on 4 front teeth. So if I show you the pictures, your jaw will
Oh my
fall away.
gosh.
So I started working there, and then and it's literally, because he was literally, I can't say you can't do this non-intentionally. So he was literally just milking insurance. And then it was people who were very low dental IQ, so they didn't know any better. And he was very nasty, so patients would eventually leave. And he would just write non-compliant, retie, non-compliant, retie. So I started working in that practice, and gradually, by the time I graduated, I was working in 7 different practices, doing orthodontics. So I've seen a lot, and then sometimes I could not get a case finished predictably, right? So I would start patients, and it looks like a simple case, but all of a sudden our patients comes back a couple of weeks later or a few weeks later, and then you see that things have changed, and then case does not look simple anymore. And then what did I miss in my initial diagnosis? And then I look back and I don't see anything. I speak to some of the colleagues, and they say, "Oh, you did this, you did that." And then I said, "No, that does not make any sense." So then I listened to Ron Roth, and then he said, "Well, because you're recording, habitual bite, but it's not always related to the jaw joint. So the minute you put the braces on, you break the muscle memory, and the bite has changed." And some of my orthodontics teachers did not believe that, but I've seen that happen, and I felt, no, this is I think Roth is right. So after I graduated, I took his 2-year course in Michigan. Well, he passed away in the middle of it, but I took a course with his disciple, so to speak. And then this was also, besides the fact that it helped me with keep treating my cases more predictably, it also put me on a different path, because I never wanted to be in the rat race of changing colors.
Yeah.
That's what I saw, and in the large practices that saw a lot of patients. It was a business model where the orthodontist wanted to do the least. So the patients come in, one assistant would put braces on, another assistant would be just changing colors, and it would be just line them up kind of business model. It's not really occlusion or anything else practice, and I wanted to be different from that. Working in those practices taught me definitely that I don't want to go that route.
Isn't that the truth though? It's when you first get out, just gaining the knowledge of what you don't want to do is just as valuable as what you want to do.
I was very fortunate in that respect, because I worked in those places and I knew exactly what I did not want to do. So I wanted to have a very boutique, small, one place where I would deliver a health service rather than just line them up and let them go. So that's how we started, and that's how I try to differentiate my practice going in that direction. So joint-based occlusion, and then airway just happened kind of naturally, because you start treating patients, starting doing expansions. And one of the things that I was taught in my Roth class is not only actually, we had a very good program director. He might not have been believing in airway or joints, but he was an incredible individual that always taught us to analyze, what did you do? So just because if you straighten the teeth and you lined it up, but it looks nice, but what exactly happened? Take an X-ray, compare the X-rays, because it'll be, if you start analyzing what you've done, you'll be in shock, because sometimes you think you did it one way, and then reality is it's not what happened.
That
It's
is so interesting.
yeah. So let's say you corrected a class 2, and what looked like a nice outcome, and you start analyzing, oh, patient just grew really well. Your mechanics did nothing. Or something, you thought you maybe changed, growth. No, you just flared the teeth forward, and things like this. So it was, looking at what you've done, kind of opens your eyes on, what's working and what's not working. And it's you can't say, uh, um, you really know,
Well,
essentially.
that's interesting because, it's like you can assume what you did. You had the intention of doing something in particular,
Yeah,
but maybe that is not at all how it all landed.
exactly.
So he was, this instructor he was someone that taught you to really analyze. And then that makes you just a better practitioner when you
Right.
really look at what you started with, what you ended with, and then now you're going to approach cases differently
Right.
in
So,
those similar, malocclusions. You're going to say, hey, I've seen this before, and
exactly right. You do these things, and then you essentially you're not only analyzing, but then you also start noticing things. Like you did an expansion in a 7-year-old, and the mother comes back and she says, well, you know what, she started breathing so much better, and she started sleeping so much better, and then she went from 3rd percentile to 50th percentile, and thank you so much. And the light bulb goes off, and then you start looking at other things, and you start looking, okay, maybe there is something to it, to that airway thing. Then
that's
you what?
so true. The patterns that you start to see within the practice.
Yeah. And then we started using, I started using my first scale expansion case because I read an article of Von Moon, and you know the story.
Yeah.
So I just it sounded like made sense. So I tried the scale expansion, almost 12 years ago for the first time, and outcome was remarkable. So okay, that's another tool. And then initially those were, all the expansion, the scale expansions sometimes were, on adults especially, they were to make room for teeth, to improve the scale relationship. And then as you do this again, patients come, oh, I stopped snoring, oh, I could breathe through my nose better. So again, it's just like, oh, cool, that's maybe there's something to it. And then you just gets more and more into it, and that's basically how that whole journey connected.
So what would you say as far as, because it's the temperature right now, the environment around expansion, helping airway health, it's there's a lot of sides kind of slinging at each other right now. And what would you say is your experience, just anecdotally, within your own practice over the last 12 years? Well, more than 12 years you've been doing the skeletal expansion. What, even before that, though, you were probably doing, some fixed bondeds or some high racks or different things.
I did. I was always geared to treating without taking the teeth out, because especially when I started using TADS in 2008, I'm in the area where the extractions are really, some dentists and some parents are very looking at extractions as a negative thing. Today's parents are very educated, or patients very educated.
Yeah.
And quite honestly, part of the reason, aside from the airways, very often I've treated cases with extractions, and when I looked at them, they were happy. I was happy at the time how they looked, but now when I see their smiles, I don't like it. Like
Yeah.
I had a woman that she was a young girl when I started her as one of my very, very first patients, and we took 4 teeth out, and she was incredibly happy when we took her braces off. And then now she has 7 children, and I've treated 5 of them already. in 20 years span. And then, in the process, and every time she comes in and she smiles at me, and then I cringe. I hate the way it looks. So it's like chicken mouth. It's nice and straight, but
The
I
teeth.
don't like the aesthetics of it. And I like nice, wide, healthy looking smile. So it's a personal preference. But I while I was on the Africa trip, I said, remember I told you that it was a group of orthodontists,
Oh
and I
yeah.
and actually I did a presentation for them on the scale expansion, and
And let me tell everybody just what happened. I mean, you just went to Africa basically and went on this amazing photography safari adventure, and it was with a group of orthodontists, and you have the most amazing pictures. Oh my gosh, they're so amazing. So while you're on this safari,
well, the
you give
safari,
a presentation.
one of my friends asked me if I could give the group the presentation on scale expansion, because few of his friends came from Australia to take my course. So I did the presentation, and some, they said, yeah, that was really cool, but why couldn't you just take 4 teeth out? It's like, I could, but I felt that this, and then there is also a doubt. It's like, oh, is it going to be is it going to be stable? This is what some people say, that it's reverts, that the nasal breathing doesn't necessarily stay put, and that's some obviously legitimate questions. But I analyze my own cases, and I see what I see, and then in some cases, if I didn't do enough, maybe there was some reversal. In some cases, I didn't, I thought I expanded X, and then I did not expand as much as I thought I did, or I see now long-term follow-ups, and there is certainly some relapses. So yeah, it's not a clear cut,
Right.
this X will happen. So we're still in the analysis, and we're still in the discovery phase of the process, but still the outcomes and of the cases that I treated with a scale expansion and still on the airway and sleep, I think that it's the change in health of you're not you don't continue to be a tooth jockey. You're
Yes,
actually providing a health service to the
absolutely.
patients, and in combination with the jaw joints and occlusion and airway, it's really feels like you're a doctor.
Yes, and you are,
Right.
I mean, it's like you're the oral physician basically. I mean,
Right.
and
Exactly.
I mean, the ADA has had their pediatric airway symposium, and there's been, just more communication about the term primary care dentist, and basically, that we are the primary care physicians of the airway. I mean, our patients see us more than they see probably most of their healthcare providers on a regular basis. And for us to be able to say, okay, you need orthopedics or orthodontics, you need to get to the ENT, you might have allergies. I mean, it's really us kind of triaging these patients and not just being tooth mechanics, because we
Right.
are educated so much beyond that. And
And and
it,
it's,
it
and it's one of the reasons I really don't like the putting labels, like some people say, like airway centered practice or airway orthodontist. I do not like that label,
and
because
tell us why you don't like that. What do you feel?
because it should be comprehensive treatment, right? You address the head, your oral head
Yes,
neck physician, right? So that's what we think of ourselves. And one of the reasons I don't like that label is because I have no names shall be named, but there is a someone who's practicing not too far away from me, who claims to be big or airway orthodontics, and then he stated off the big stage, when he showed purely dental expansion, not skeletal, just moving the teeth out with some nonsense appliances. And then somebody asked him, well, dude, you just moved the teeth, you're out of the periodontium, you're not, you're increasing oral volume at the expense of something else. And his response was, I'd rather the patient's teeth fall out, but so they could breathe better. Well, that's really not it's really not
that's
a good philosophy, right? You can't treat one thing at the expense of the other thing. You can't treat airway and have occlusion fail, or have perio fail, or have so I like, so if I had to put a label, it's a comprehensive approach.
Yes. Yeah, it
You should
is.
include all the goals: airway, occlusion, aesthetics. You can't treat one at the expense of the other. Sometimes you have to compromise, and the patient doesn't want
Sure.
surgery.
Sure.
You might want to, you might not be able to achieve certain goals, but treat one at the expense of the other. It's not, just to me, it just does not make any
Yeah, I
sense.
think that's a really good point. Is I think when things get really when topics are really hot and things are new, everybody jumps on kind of that bandwagon of airway minded, airway centered, and the intention is good. The intention is good. They're trying to let people know, hey, I'm a little different. I'm actually going to take your airway into consideration, whereas maybe somebody else wouldn't. But to your point, we as healthcare providers should be comprehensively looking at the whole complex anyway. And it's raising that bar so that all of us are comprehensive and looking at all of that. It's definitely it's changing, it's happening, not as fast as I'd like to see it. I mean, I wish every orthodontist was, practiced like you did. And we're definitely seeing changes, but there's
They're very
hesitancy.
slow. They're
It's
very
very
slow.
slow. So what do you think? What are your thoughts on why there isn't as much of a comprehensive diagnosis? Because really it's anybody can really straighten teeth. Okay.
Absolutely
A
anybody.
software system. I mean, there's
Yes.
Invisalign doing amazing things. There's your software, boom, it straightens teeth, but it's not comprehensive, or it's not taking other things into um, consideration. So, what is the hesitation for all of us within dentistry and within orthodontics having a similar diagnosis strategy?
Well, especially for when it comes to an orthodontist, you have to realize that, especially in big practices, they have systems that's been set in place for decades, right? Patients come in, they have, especially like Midwest practices, it is very easy, enormous money making machine. So patient comes in, there is a system to get the patient in, there is a system to put the braces in place. It is
Assembly line of sorts.
assembly line. So it
Yeah.
is very comfortable setting where it generates very nice income, and then why would I want to disrupt that? And where it's just so makes it very fairly predictable. And if I start thinking about airway, if I start thinking about this, then I have to change the systems, and it's people are very uncomfortable with changing systems.
Yeah, that. I mean, that's change is uncomfortable.
Changing a couple, but also,
Yeah.
like you just said, people get on the bandwagon and they don't look sideways. And I really love the fact, like literally, I have right here your article, pinned
Oh, yay.
to my little board over here, that and then for just because people have some sleep issues, not always maxilla, it's not always
It is
mandible, it's
not. It's
always
for those that didn't know what he held up. It was a little tiny article I wrote in our ASAP newsletter about restless leg syndrome. And that is and sometimes people don't want to hear that, and they
yeah,
don't
people
want to
just
ask the questions. It isn't all airway either.
exactly, or it's not always, it's like there's other things in the body that could contribute to this, and you can't just
Yes.
start expanding everybody just because somebody doesn't fit the measurement category.
And okay, that right there is beautiful. Okay. This is what I think a lot of people, there are naysayers that might be looking at the expansion, the airway community saying, you're just expanding everybody. If they don't meet your measurement criteria, you're throwing it in, they could be functioning just fine. And I agree, there could be people out there like that, but that's not the majority. So I think that it's giving, there are groups out there are companies out there that it's just, here's the measurements, Here's a little
Here's an
class.
appliance.
Here's an appliance from a weekend course. They broad stroke everything. We're going to treat mouth breathing without including an ENT, as if mouth breathing was the condition. And it's like, no, mouth breathing is a symptom of something else. So it's like the wild, wild west. I keep saying that term.
I have a woman that came into my practice, and she says, I need an expansion, and I need to rest, and I need to sleep. And then she's in this stupid orthotic that somebody gave her that she's been wearing for 2 years. She's incredibly uncomfortable. So we put her on a splint, and she says, do I need surgery? Do I need expansion? And I tell her, well, you might need a surgery to fix your bite because you got an asymmetry, but your sleep doesn't seem to be related to your maxilla is not narrow. Your airway volume looks okay. You know, your sleep test doesn't show that you have a sleep apnea. Something else is there. Why do you want me to jump and expand you and then do a surgery, and then this will not fix your problem? So but people they have a preconceived think that they have to get this done in order to feel better, and that's not always the case. But people just jump and do it, and
it's unfortunate because there could be a provider out there that's like, sure, get in my chair, let me expand, and not really doing the deep dive to say, let's step back and see what this could be. Exactly. The other thing I think too is we have possibly, you know, a lot of healthcare providers in dentistry, a lot of dentists and orthos that they're like, I don't want to learn all of this.
Why?
And yeah, they're like, I'm making decent money. I'm not killing anybody directly on the weekend from what I'm doing.
They're providing a service what they learn. They get the crown, they make the aesthetics better, they make the teeth look better, patient feels better, you know, psychologically, and they're happy before it. That's
So I do think this is what's going to happen is just more conversations like this, just where we can all come to a table and not throw arrows at each other, and understand that what you're seeing in your practice, I mean, you can't deny what you're seeing and what you're experiencing in your practice. Yep. And as a healthcare provider, you know too much now. You're not going to go backwards and just to satisfy somebody else.
Let me tell you this also. Same person I mentioned before, I had a conversation with him, and then I said, you throwing this 5-cent appliances into patients' mouths, and you charging an arm and a leg, and do you have a visual proof that you've done what you claim you've done? And he said, no, I just go by patients, how they feel, and subjective. Well, it's not treatment.
No. Because you got the novelty effect. Sometimes people just feel better because they want to feel better.
Yeah, that's very true.
I mean, you've got a placebo aspect, and that's very real. Yeah. And, you know, people are desperate for wanting to feel better. And sometimes they're like, oh, I hope this works. And at first, and sometimes maybe things are helping just a little bit, but you're not getting to the root of the problem. And then what happens? All of a sudden, symptoms completely show their ugly head again because you didn't get to the root of the problem. All the time. And again, medicine, dentistry, orthodontics, it's a practice. I mean, we're all learning. We're not perfect. We're doing the best we can, but I think we just need to have more collaborative conversations and less mudslinging, you know, and I think there's fear. I think there's a lot of fear that's driving some of this anger because people don't want to change. And when you start, I think also they don't want to look back and say, you mean I haven't been maybe treating people optimally? Just like you said.
And that's okay.
None of us practice the way we did, even I don't 5 years ago.
You know how they say, so at first you're unconsciously incompetent, but at some point you become consciously incompetent.
Yes.
Then you learn, and then you become more competent. And when you practice unconscious competence, that's when you reach a certain level. But you're going to go through those steps and you're going to discover that some of the things that you've done, it's just like myself, I've done things that
Myself included.
you know,
Yes.
I look at some of the cases and yeah, I could have done better. This is not optimal, or I could have done this, or this is this, and that's okay. Just, you can't drive you, let you, this, you can't let it drive you mad and then try to
Yes.
treat everybody.
You have to
No,
give yourself some grace,
yeah,
and no, you were doing the best
you're
with
doing
what
the
you
best
knew.
what you knew. Exactly.
Yeah. And that's what I think, and even more people, I mean, on both sides need to be saying that, on all sides. You know, it's extending grace to our colleagues to say, I think at the end of the day, we all want to do what's right for our patients.
Yeah.
I think dentistry, orthodontics, we're really one of the most trusted professions because they know we really do want to, we have good relationships with our patients and we want to do the right thing for our patients. And so I think if we just assume the best in each other instead of assuming the worst, and just understand it's scary, change is scary for people. And so maybe easing up on, everybody must do this. Well, you know what? Not everybody practices the same. Maybe you don't want to treat kids. Maybe you only want to treat adults. I mean, if you don't want to see people and do, skeletal expansion, or you don't want to offer that in your practice, that's fine.
Yeah.
But identify the candidates that would benefit from it and refer appropriately. Identify the kids that need help and refer appropriately. That's all really anybody's saying. We're not saying everybody must do this within their practice. No, but screen for it and include the airway and include sleep health, because what we do in the mouth, I mean, the airway is right behind it and right above it. So it affects it. And to say it doesn't is silliness. Where do you want to see your profession in 5 years?
Well, where I want to see and where I will see, those two different things.
Okay, let's talk about
what I want to see is I want my specialty to be more in tune with what we just discussed. Not be tooth jockeys, but be more comprehensive to the rest of the mouth, and be mindful of periodontium, be mindful of joints, be mindful of airway. Not just line the social six and be done with it. But the unfortunate part, I think in 5 years or so, I think we'll be heading in two completely separate directions. There will be practices that joining into large DSO corporate groups, and a lot of orthodontists joining those groups. So they will go into this, line them up. It will be a practice that's not dependent on practitioner. It'll be just a practice where the patients will just come in to get their teeth straightened. And there'll be practices similar to mine that will go in the opposite direction, which will focus on, joints health, and then have a comprehensive diagnosis and comprehensive approach. And it will be probably much smaller practices, but, I sleep well at night. So
yes, and more niche practice.
Yeah.
And you know what I think? I mean, that kind of exists already now. You have your assembly line, or you have your, we don't want to talk about what's above the palate. We don't want to talk about what's behind the palate. We just are going to, spin around the white things. That's what we're going to do.
That's right.
And it's okay. I mean, and there's a lot of people, they're very, there's not anything really going on with them, and you know what? Spinning the white things around isn't going to affect them at all. They're just going to do just fine. We're just asking that. Just look at your patient as a person in the chair. And if you see dark circles under their eyes and mouth breathing and chapped lips, get them to an ENT and do some true orthopedics on this patient and improve the quality of life. Because especially with kids, Ilya, we got a window of time where we can work with that growth and development.
Yeah.
And then after that, I mean, thank goodness for, the advances of skeletal expansion, the things you're doing. You can do amazing things on adults that are no longer growing, or even the non-growing child. So we do have option B. But man, if you can hit the sweet spot while they're growing and work with the growth and development, and then really those neurocognitive deficits that occur in those really young ages.
Yeah.
If we can get to the kids then, because those are permanent and those are pretty much locked in if we don't get to them by 6. So it's
yeah, and
really,
that's another thing that I would like to see changed is American Association of Orthodontists says recommends for the child to be seen around age 7. Well, I'd like them to be there, when they're 3 or 4.
yes, that's when all the neuro issues are happening. I mean, we've got too many studies out that, I mean, they don't even have anything to do with obstructive sleep apnea. It's just literally snoring. Okay. These kids are snoring. There's neurocognitive deficits. We've got case studies where 12,000 kids were studied. This is not even a what if. This is the facts. This is what we need to start doing as healthcare providers and seeing these kids. So yeah, I just very much appreciate what you're doing and what you're doing for ASAP Pathway, what you're doing for our profession as a whole. I mean, people come from all over to have you do their own expansion because you're so good at it, and you've got it down to an art, and we appreciate you sharing your knowledge. And look, it takes a lot of time to put a course together, and a lot of work. So we just appreciate you. Before
Thank you.
Before we head out, I just have 3 questions for you. And I'm going to take you back to your childhood. Now, I know you grew up in Russia, so I don't know what kind of, culturally there could be some differences with food and stuff like that. But
Sure.
What was your favorite meal as a kid?
Potato with some fried mushrooms.
Potato and what was that called?
Just that's what it is. It's just like a very traditional, like if you ever go to a Russian restaurant, they'll have fried potatoes and mushrooms on the menu.
Oh, it's fried potatoes and fried
Yeah.
mushrooms too.
Yeah,
Oh,
they fry
that sounds
together
good.
in some butter. It's just like,
Oh, shoot, that sounds good. Might do that tonight.
very
Does
good.
it have a name for the dish?
No, I mean in Russian that's what we call it, potatoes with mushrooms.
Potatoes and mushrooms.
Yeah,
Okay.
but it has to be fried very specific way. With the usually you chop up the mushrooms, chop up the onions, you saute it all together, you fry the potatoes, and you put them all together,
Ah,
and the potatoes has to come up like very like crispy and like a little bit fried on one side, like these time you slice them thin. It's just like wow.
ooh, that sounds really good.
Yeah, it's a simple food, but man, it's good.
Oh, it's all the basics. I mean, butter and potatoes. I mean, you could throw anything on that and I'll eat
Yeah,
it.
exactly.
What was your favorite when you were a kid? What was your favorite vacation spot that you would go to? One of your fondest vacation spots?
Well, I grew up in Soviet Union. It's not just Russia. So Soviet Union was very, kind of separated from the rest of the world.
Yeah,
You
yeah.
couldn't easily travel outside of the country, but within the country, it was just mostly my parents had a passion what we do. We just go to a particular place somewhere in literally nowhere. There would be like a river, so we had a folding kayaks. They would pack
Oh,
stuff for like a week, 10-day trip. It'll be usually my parents, us, me, my sister, then a couple of other friends. Sometimes was their kids, sometimes not. It'll be a group of like let's say 3 or 4 kayaks, shall we say, and we just we would just kayak down the river periodically, stop, make a camp for a couple of days, fish, relax, eat, enjoy the nature, and it would be taking place anywhere in within Russia. So
that sounds heavenly. That sounds so relaxing and like
yeah,
good memories. Good
yeah,
memories.
very good memories as a kid. Yeah.
And it sounds like you're still carrying your tradition on of your trips because of your most recent one.
Oh,
So
I think they gave me the travel bug. That's for sure.
yay, they gave you the bug. That's for sure. And finally, who was your favorite superhero when you were a kid?
We didn't have superheroes. Lenin was our superhero.
Oh my gosh. See, this is the cultural differences. So Lenin
Yeah,
was your
yeah,
superhero.
yeah. Just like right now in North Korea, the Kim Il Sung is
Is
their
their
god
superhero. Well,
superhero.
knowing who the superheroes are, who would you have picked, you think, if you had been exposed to superheroes in like Western culture?
I don't know. Yeah, not sure.
Not sure. It's like, isn't that
I'm
so
not big into
interesting?
superheroes in general. So
That's so interesting. I love asking those questions because, we just assume we all have very similar, upbringings and childhoods. And, childhood's so important and it shapes who we are. And I
hey,
love hearing
listen,
people from other
my
cultures.
childhood, I had to make my own toys, so it was so cool.
Yeah. So your kids are like, you probably pull out the dad stories are like, hey, when I was a kid, I got a stick and a can, and that was my toy. And I used to play with that.
That literally was the case. A lot of times, I mean, if we were able to get some sort of like a little metal soldiers or something like that, that was like a treasure.
Like that was a treat. That was a
That was a
treat.
treat. But in general, I mean, it had some positive. I think that stimulated imagination.
It sure does, because you've got to be creative if you're going to create your own fun.
So I don't look at it as necessarily a bad thing.
Yeah. Well, look what you're doing now. So you're pretty creative, I'd say. Always engineering something new. He's always showing a picture of like, look what I've done with this appliance, and I've welded this and added this to add improve physics. And I'm like, oh my gosh, Ilya. But now we know why. You've been a creative person your whole life. Well, thanks for joining us today.
Thank you for having me.
Oh gosh, it's a pleasure. And anybody wanting to take his live courses, he's amazing. And I'll have more information in the links. Everybody have a wonderful, wonderful day.
Thanks, Stacy.
Thanks, Ilya. Bye-bye.
Bye. Enjoy your day.